And the recording will be posted on Confluence, so you'll see a link to it on today's minutes page. All right, welcome everyone. We have an interesting agenda today, which we'll go over. But before that, I just want to review our last meeting minutes. So these are our minutes from October 30th, and this is just to approve the minutes. So I'm going to read out the statement. So you've received the minutes. Are there any corrections to the minutes? And hearing none, if there are no objections, the minutes are approved as printed. All right, so we'll start with today. So welcome everybody. I'll read the Gravity Project Antitrust Practices Statement. The Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. Individuals speaking or providing written communication shall refrain from any discussion which may provide the basis, oops, one second, which may provide the basis for any inference that they have agreed to take any action relating to prices, services, production, and allocation of markets, or any other matter having a market effect. Participants shall not discuss their pricing or others' pricing or any term that might affect pricing or fees, such as costs, discounts, terms of sales, or profit margins. Adherence to these guidelines involves not only avoidance of antitrust violations, but avoidance of behavior that might be so construed. And for our agenda today, we'll be discussing the payment and reporting report release. So we do have that report posted on Confluence. I'll share it in the chat. We also have a blog associated, and we have slides as well. So Aaron, I'm happy to present the slides, or if someone else from the team wants to have them up on their screen, that's fine as well.
Yeah, thanks, Sarah. Yeah, I think I'll turn it over to Corey Smith to do the introduction here.
Yeah. Hello, everyone. Can you hear me okay?
Yep, can hear you.
Great, thank you. Yeah, so thanks everyone for joining here today. Good morning, good afternoon. I'm Corey Smith. I'm the technical director, and I'm just going to kind of set the stage a little bit about, why we're talking about payment and reporting discovery at this session today. So next slide, please. So next slide, please. I guess I can quickly review the agenda. I'm sorry. I'll just do that quickly. So today we're here. I'm gonna just talk briefly about the Gravity Project drivers, and then we'll turn it over to the team to talk about the payment and reporting discovery findings, and then we'll talk about terminology to support payment reporting. We've labeled this session a listening session, so this is a great place for us we want to share with you some of the work we're doing. We want to listen to you all to help us stay community driven, and that's all I'll say about that. Next slide, please. All right, so there were kind of three big drivers for why we're here today, about talking about payment and reporting in the context of SDOH. So there's the Gravity Project strategic goals, social care co-design, and some member-led prioritization activities that we convene. So as part of our convening work, next slide, please. Baked into our Gravity strategic goals, which were refreshed in March of 2023, you'll see here one of the goals that our steering committee, operating committee, the Gravity community agreed to was to accelerate data standard solutions to address the payment and reporting needs of community-based organizations and other stakeholders. So that was sort of, it's baked into our objectives. Also, next slide, we, as part of our another convening and another great piece of work that the Gravity did, was this social care co-design, which was a partnership with Civitas for Health, Networks for Health, support with Robert Wood Johnson Foundation, where we convened across 6 sessions a range of different social care provider stakeholders and produced a report which you all can read. But for the purposes of today, one of the new sort of use cases and areas that group identified was also related to reimbursement and investment, sort of use cases where there are existing pain points that standardization might solve for. And that's the point here, that we're hearing from our community that there are needs and requirements related to reimbursement and investment that standards may help. And before we go off and just build standards, because another one of our objective is to build is widespread adoption use of our standards. We wanted to better understand, what the requirements are. And so the project, the payment reporting discovery project, was one such project that Gravity spun up in response to these findings from social care co-design, our strategic objectives, and convening our groups to prioritize our activities, was to say, okay, let's go out and do some more convening to better understand some more specific areas that of standards that we could build. And so with that, I would like to turn it over, and the rest of the team will explain in a little more detail about what the payment reporting discovery process was and what we found.
Awesome. Thank you so much, Corey. And we can go
Yeah.
to the next slide. So I will kick us off. Hello, everyone. My name is Emily Anders. I am the Director of Payment Strategy at Unite Us, which means that I have the opportunity to work with and learn from stakeholders across the country as they are planning, implementing, and evaluating their health-related social needs, or HRSN service reimbursement programs. And I am really excited to share some of the findings with you all. And you will hear from my co-facilitators for this discovery project throughout kind of the slides. So Corey Spears and Elena Kalinowski co-facilitated this with me. And Corey and Elena, if you're on, I definitely please add any colored commentary as I go through it. So with that, if we go to the next slide. So hopefully some of you on the call have had the opportunity to read the discovery report. So again, it was posted online. And if you haven't had the chance to yet, we're going to provide a brief overview of the various sections. That's what you're seeing here on this outline slide. But if you are excited about this work and want to help us continue this work, I definitely recommend that you read the report afterwards. So I'll start with the executive summary. And so this is just kind of an overview of what our goal for the project was, the process that we used to do this discovery work, and our initial kind of recommendation in terms of scope. Then a background section. This was a really critical component to be able to kind of express the various stakeholders' perspectives, their challenges that they're facing, and opportunities. And then finally, the bulk of really the standards portion is in this resource landscape analysis and recommendation section. So we'll go through it at a high level, but we really broke it down into common activities that we're seeing across these programs, the actors or stakeholders who are engaged in that specific activity, existing exchange standards. So what is being leveraged today in these programs, or what is available to be leveraged, existing data and coding standards similarly, and then Gravity project recommendations. So what's potentially within Gravity project's purview to do some development, and then structural recommendations. So kind of tying it back to various stakeholders' perspective and pain points. What are things that Gravity project might not be able to address, but other coalitions, groups, policy changes, what present as barriers that could be removed to be able to scale these types of programs. So with that, let's get into it. So if we go to the next slide, again, the executive summary. So our goal for this whole discovery period was to understand and define the existing landscape for community-based organization, or CBO, reimbursement, and identify the components of the CBO reimbursement process that would benefit from national standards to be developed by the Gravity project. We did this over the course of a 6-week discovery period. And on the next slide, we'll have our attendees. And the committee during that time discussed various funding types, those activities that I explained earlier, actors, resources, and gaps in the existing process. And our recommendation for the discovery period was to focus initially on standardizing HRSN, health-related social need, reimbursement within Medicaid, specifically 1115 demonstration waivers, with subsequent extension to other funding streams. And we kind of provide that rationale within the executive summary, but just to provide a summary for you all, really, this was because these 1115 waivers have an increasing popularity recently, which means that there are lots and lots of stakeholders across the country that are currently either designing or implementing or maintaining these types of programs and could potentially benefit from these types of standards to be developed. Also recognizing that standards within these processes, it's a big challenge and opportunity. So you really just got to start somewhere. And so this is where we recommended to focus as a starting point, but really understanding that there is a lot of overlap within these programs and other types of funding streams. And so hopefully being able to extend to those later on. So if we go to the next slide, a quick look at the participants in the 6-week discovery period. So I'm not going to list off all of the names, but we had really great representation from our community-based organizations, CBO partners, from payers, providers, our federal partners, and technology. So we were really well represented across the board. And if we go to the next slide. Okay, into the background. So again, it was really important to understand for both community-based organizations and payers across the country as they're implementing these types of programs where standards don't exist, what are common challenges that they face, as well as what could their ideal state look like. So starting out with CBOs, their common themes were really needing to be able to better facilitate and streamline eligibility checks, the enrollment and authorization processes due to inconsistencies in requirements and process across payers that they might be contracted with. And then also similarly, having to navigate those different requirements and different formats for actual claim submission with a lack of timely remittance notifications if receiving any at all. And again, this is where standards are absent. For payers, common themes that they articulated were needing to receive coding related to the services that they're paying for in order to effectively evaluate these new programs' outcomes, and a desire to leverage existing healthcare exchange standards for CBO reimbursement. So just kind of adding in CBOs into their existing provider networks and adding them into their existing processes so that they can scale their programs. And those kind of pain points that the CBOs and payers were referencing have implications on the success of these programs. So just to call it out, there could be a delay for members to receive services if there are lengthy eligibility, enrollment, authorization processes that CBOs are having to navigate with different requirements across payers. There could be a delay for CBOs to be reimbursed, again, with different requirements, different formats that they are required to submit those claims in, which in some cases we've heard on the ground has caused smaller CBOs to drop out of the programs due to the difficulty of navigating those requirements. And last but certainly not least, an inability for payers to prove out outcomes or be able to scale their programs. So that data collection piece and being able to codify those services is really important for payers. If we go to the next slide, I am going to start with kind of our final recommendations, or not final, because everything is always being worked on as we learn more information, but the recommendations we landed on for next steps. And then I'm going to go into and kind of better define the activities that we centered around. So after reviewing the feasibility and structural barriers for implementation within each of the 5 activities that, again, we centered around, and I'll go into in just a bit, we recommended, or the Discovery Committee recommended, that Gravity Project next steps focus on first, terminology development for CBO payment and reporting activities, which Sarah DeSilvi is going to give an update on in just a couple of slides on what her team has already been doing related to that and their plans, continued plans related to that next step. And then secondly, continued implementation discovery for some of the specific activities with key stakeholders where those waivers are implemented or in active implementation. And Corey Spears is going to talk a little bit about next steps for that one. So if we go to the next slide, and again, I'm kind of going through this quickly. So I strongly want to encourage anyone interested by this to read the report so you can get all of the details broken down within that. But as I mentioned, we centered around 5 key activities. And I also want to caveat this to say for anyone who has supported an 1115 waiver or an HRSN reimbursement program, the activities as we've defined them might look a little different depending on what state you're in or what your role is. And that's part of what's so important about terminology development, right? So when I say Medicaid eligibility verification, it means the same thing to everyone else. So take that with a grain of salt as I'm going through these. But again, these are the commonalities that we're seeing in these 1115 waivers across the country. So I always think of this as a funnel, and my camera's not on, so you can't see me doing all the hand motions, but I'm at the top of the funnel. So first and foremost, for Medicaid eligibility verification, this is like step 1. So this is for any member to have access to these new types of benefits, these HRSN benefits. They have to have active Medicaid coverage, and for a CBO to get reimbursed for those services, the member has to be covered with the payer that the CBO is contracted with. So really confirming what that verifying what that Medicaid coverage is. That's step 1. Step 2, there's typically some sort of enrollment process. So it's not enough in these programs to just have that active Medicaid coverage, but rather you need to meet some sort of predefined combination of clinical and social risk factors. So for example, maybe it's this member is a pregnant individual and they are also food insecure. Therefore, they can be enrolled into the program and have access to these new services. There's also we've seen variants that it might not be a clinical risk factor, but it could be that the member falls within some sort of target or priority population. So I was recently incarcerated and I'm food insecure, therefore I can have access and be enrolled into the benefit. Then we have authorization. I will say, I think this is where the most variance in terminology exists in just and how different stakeholders are handling this process. So you can think of this in healthcare terms, like the prior authorization concept that a payer needs to provide prior approval before the member gets access to a specific quantity or duration of this benefit. Also, we're seeing if it's not direct kind of payer intervention, it could just be there are benefit maximums that a member could be eligible for. So I am enrolled in the program. That means I can have access to up to 10 medically tailored meals over the course of 6 months, as an example. And I'm not going to go over all of the actors' existing standards recommendations right now, but again, just want to provide some color to those activities for you. And then if we go to the next slide, finally, we have service documentation and then claim submission and remittance. So for service documentation, I'm a community-based organization, and what are the actual documentation requirements that I need to ensure that I'm capturing while I'm providing this member these new benefits. And then finally, claim submission and remittance. So this is the actual way that a community-based organization is required to submit a claim. What format does it need to be? What are required fields, etc. And then the remittance advice that they're receiving from a payer when something is approved, denied, so that a community-based organization can understand what was submitted potentially incorrectly, what changes they need to make so that they can resubmit and go through that dispute process. Okay, I will pause and just check the chat to see if there are any questions. I see a question from Lucy. Pain point, coding, driving services provided versus services needed. Did this come up? Can this be avoided? Lucy, is this related to screenings specifically versus, so services provided, meaning what was actually provided to the individual member versus what were all of the services that member actually needed but wasn't able to get, or the CBO isn't able to be reimbursed for those? Is that an appropriate interpretation of your question?
Yes.
And I believe that did come up. I want to see if Elena has been able to join the call yet, because in my memory, I think we did have some discussion about that. And if it didn't make it into the report, we can always add it in, because I think that's a really valuable like documentation and from a data perspective, being able to capture that to prove out the importance of those types of services and that type of funding.
Let's learn from healthcare that coding drives services. And let's
Absolutely.
try to avoid that as we expand very needed payment to a whole new sector of services.
Absolutely. I am writing that down right now. And then I see,
Another pain point.
yeah, if CBO is authorized to provide services, does that automatically mean no balance billing if reimbursement is deemed inadequate? Are you asking if that's being kind of written
If you're
into program
a
manuals?
if you're a Medicare certified provider, that legally means that you will accept Medicare reimbursement regardless of that reimbursement's relationship to what you actually billed. So I'm asking whether that concept extends now to this realm with respect to Medicaid payment for CBO services. And if not, I would consider this a very serious issue that needs to be, I'm not saying that gravity can change this. That would be out of the question. But if that concept of accepting payment from Medicaid as payment in whole, if that is not present legally, this is really serious, because patients may start getting billed for things that they agreed might be needed, but had no idea they were going to have to pay for. And even if they did and they called up to see how much it would cost, they wouldn't get an answer. So that's why I'm raising this.
Absolutely. That is a great call out. In my experience, what I've seen thus far is that is not something that is being implemented in these programs. But I can absolutely ensure that we're documenting that as a potential, excuse me, structural recommendation within the report.
Thank you.
Yep. Thanks for bringing it up. All right. I'm seeing some others in the chat. How would this standardization work when Medicaid programs, waivers, and often services look very different depending on which state that you are in? Also, how have CMS and state Medicaid agencies and staff participated in this process? Great question, Marissa. We're going to get into the next steps for those kind of implementation discovery, meaning ensuring that stakeholders like state Medicaid agencies and staff and other stakeholders are involved in the process, making sure that there's like an appetite for that. I think, again, in my experience, what we're seeing is there are commonalities across the HRSN reimbursement portions of these Medicaid programs. Even if they're referred to as different things, there's still common steps that need to be accomplished for these programs to run. So even if, like I mentioned, authorization is looking really different across the landscape, however, what we are seeing is that a claim submission is a common requirement. So things need to actually be submitted as a healthcare claim, whether that's through an an 837 or a CMS 1500. That's a common requirement. So in areas where there are those commonalities, I think that's where there's the opportunity for that type of development. But of course, ensuring that we're bringing along all of the appropriate stakeholders in that process. And that's kind of why we're here with this next step.
And Emily, if I may add to that.
Please,
This is
Corey. Thank you.
Corey Spears. There are commonalities, and the points where there are commonalities, we would want to push towards standardization so that we're can leverage those commonalities efficiently. But we recognize that there will always be differences. There's differences in the traditional healthcare space too between payers, right? And so let's standardize on the places where we can standardize, where there is commonality, and enable kind of discovery, and enable organizations to communicate their definitions or the requirements in a standard way. So the requirements may be different, but they can be communicated in a standard way and be discovered and then responded to. So sort of a framework.
Thanks, Corey. And I'm seeing questions answered in the chat. And Matt, I see you have your hand up. Did you have a question or comment?
Yeah, two quick questions.
Yes.
Are we seeing like a good portion of the claim submission going through clearinghouses, or is it mostly happening kind of on a individual vendor to payer basis? And then the second question is there, how big is the problem of, they call it portalitis, where they make the community-based organization go to a portal to input that data that's already in their system and it's not API driven?
Great question. I'm going to try to answer both of them. So first, I think there is a lot of variance in the claim submission process. I will say, like, the work that I am familiar with on behalf of Unite Us it's just working really closely with payers clearinghouses. However, in places that aren't utilizing X12 EDI 837s, it could be just utilizing and submitting a CMS 1500 form. So I think every state is approaching it slightly different, but it does end up needing to be submitted as some sort of claim. And then for your question about portalitis, I've never heard that word, but I like it. I'm going to start using it now. I don't know if we have Elena Kalinowski yet. I know she was hoping to be able to join in the latter half of the meeting, but that was a lot of her organization's testimony was about needing to kind of log into every payer's specific portal. And I can't speak to that directly because I don't have experience with that. Yeah, go ahead, Corey.
No, I just say I think that particular portalitis one, I think we've heard that in co-design. I think we've heard that in this report. So I think that is a pain point that we are hearing loudly and clearly. The need for some social care organizations to sometimes log into 10, 20, as a function of how many payers and programs they work with, so too does the number of portals they have to log into, increases.
Yep, exactly. All right. Anything else that I missed from either Corey's or Sarah before I pass it off to you?
I guess I just respond to Ryan's question about our focus being on Medicaid eligibility and enrollment, and question about the other 300 plus federal, state, and local government age services and many other things. And I think the question actually includes some of the answer there, in that we wanted to focus on I say low-hanging fruit. This isn't simple at all, but where there was at least some more commonality and fewer things to that we could focus on, noting that there's a wide breadth of different services and programs and things out there, and we wanted to see where we could start to get a little bit of traction.
Yep, exactly. Thank you, Corey. All right.
Emily,
Yes.
sorry, I didn't raise my hand. Just one more question. In your discovery process, do you have any sense of whether the Medicaid agencies with 1115 waivers, which I take to be at least a primary initial target, are they working through health plans or not?
There's variance.
That's
There,
going to be just a gigantic variable because health plans administering reimbursement to CBOs could look quite different from a state agency doing that. No?
yep, definitely. I will say, so just off the top of my head, in states that have active programs, California, Oregon, North Carolina, let's see, Massachusetts soon. There is, the MCOs are reimbursing the community-based organizations directly. In some states like New York, they might be reimbursing them through a different mechanism. So through a kind of convener type of entity. Those types of conveners are also popping up in California, we've seen, if you're familiar with the community care hubs. So there's variance, but there are a lot of states where the plans, the payers are doing that direct reimbursement.
Well, I'm going to be very optimistic and say if Gravity comes up with standardized coding for HRSN, is that right? In theory, one could argue that any payer could adopt this. The reality may be that payers are getting their instructions from elsewhere, and so either they haven't adopted anything or they've already adopted something, and this would be an overlay. But in theory, if we do a good job, this is the ultimate basis for exchange and communication. So everybody should be able to do it. That's what I'm hoping. Thank you.
Lucy, I'm right with you. I'm hopeful for that too. So thank you for saying that. All right, with that, I am going to pass it over to Sarah DeSilvi to talk about some of the next steps that her team has already been doing related to developing terminology to support the programs. So Sarah, over to you.
Hello, everybody. And Lucy, I feel like you queued this up perfectly, which is not surprising. I have the honor of talking about how the Gravity team participated in the terminology division, participated in the discovery, of course, but then also how we are leaning in to support recommendation 1, which is the terminology to support CBO activities involving payment and reporting. So these are going to be tangible things, and then we'll have a discussion period at the end of the call just to make sure everyone's questions are answered. Next slide. So the focus, the recommendation 1, again, from the discovery was, as we try to sort out standards for exchange and reimbursement, terminology, developed terminology to support CBO payment and reporting activities. So we had an approach to addressing this recommendation. We knew based on, so in fall of 2023, as part of the the playbook released by the White House and the HHS social determinants of health strategy in fall 2023, the Medicaid CHIP coverage of health-related social needs services table was released. And it's been a very good guide for many entities on health-related social needs services that are supported by Medicaid and CHIP. So we set out to try to represent the services that were contained in the table to address the first recommendation, and I'll tell you how we did that specifically over the next slides. Our approach was making sure at least all concepts are represented in SNOMED CTs for granular reporting specifics, and because there is a known paucity of HCPCS concepts, which are, we're going to go into what those are in a second, but it's healthcare common procedural codes to support social care services. What we know very clearly is that states are rehashing HCPC concepts across different waivers and programs to try to represent the complexity of how CBOs and social care experts are taking care of individuals through Medicaid waivers and through in lieu of services arrangements. So we thought we're going to go forward with specifics in SNOMED CT and try to elevate priority social care services and HCPCs. And we're going to talk about how we did that in over the next slides. And then we also just wanted to think, again, based on the Social Care Voice Co-Design report and based on the discovery and based on everything we're hearing from our friends, reporting is not always just about payment. You know, sometimes the outcome of an action is enrollment in a program. And Brian, this kind of relates to what you were mentioning regarding different eligibility requirements. Again, not solving the complexity of social care services and human services eligibility verification, but knowing that Gravity had an area to support documentation of enrollment in human services. And also just through our discovery and through our work with states and other entities, understanding how critical it is to have standards for documenting enrollment, given eligibility for some services and some waiver programs requires understanding enrollment in like underlying federal programs such as food stamps or housing, Section 8 housing vouchers, etc. So this is our approach, align with national standards such as the coverage for health-related social needs services table, develop granular concepts in SNOMED CT, develop HCPC concepts to represent priority social care services as able, and support documenting enrollment in human services, both for reporting and care planning. Next slide. So how we went forward with SNOMED CT for granular reporting, and actually, can we go back one slide? I just want to make sure, I think Sarah B must have put it in, but if we can put in the coverage of health-related social needs services table, this is, again, like the report, it's a really fundamental reference that we use in Gravity across all of our intervention, methodology, like it's a key source of reference. So it's on our, I think it's on our Confluence and our references, but it is a pretty important thing to look at, not in this meeting, to understand why we built what we did. I just want to make sure that everyone knows that link is here, and then it's widely available. And again, it was part of that White House playbook release in fall 2023. Okay, now we're ready to go forward. Next slide. All right, so we're lucky to have a key implementer and state help us in the use cases and prioritization of elements on the table due to our relationship with New York in designing their waiver. So over the course of 2023 and 2024, mostly, we worked with New York to represent the services in the 11 to 15. And the important thing to know is always the standard of evidence was a national driver, other state entities. So even though New York was the use case, we always referenced national standard because we developed national standards. So terms follow also by requirement, Gravity's evidence-based approach for aligned domains, right? So we've already encoded all of the core, USDA programs for food insecurity, other programs for HUD, homelessness and housing instability, or transportation insecurity programs and utility insecurity. We just did that this spring as well. So we were able to ground all of our terminology development for the coverage of HRSN services in line with that table to support waivers and other Medicaid programs with that base evidence. The majority of concepts were built with the provisioned facet of the Gravity framework. So if you come to Gravity terminology meetings, we define everything, even the syntax we wrap our programs around. So when we were trying to support services on the table, we realized it was very much within the reimbursement use case. And so we built concepts, provision of blank, which is a service or provision of equipment, like provision of air conditioner or air filtration device, kitchenware. All these concepts will come. Some of them are here now and some of them are coming. So we had our framework, which provision of payment for the service. And that way the CBO can transmit this, and it's a specific standard representation of what happened that aligns again with the coverage of HRSN services. And, and it's that ticket, Lucy, you were speaking to, right? Or provision of the equipment, which again can testify to the same thing. So we're going to post we're going to post a summary soon of all the concepts we built to support the table soon, but I'm going to give you a highlight of what we did on the next slides. So if you go to the next slide, you can see this is an example of concepts that we built, again, directly referencing the Medicaid coverage of HRSN services table, directly supporting waivers, in this case, the use case being our friends in New York. And these are the ensuing concepts. Immense thanks to the terminology team for the work of doing this. It was like, wow, as we were doing utility and security, we were meeting regularly to ensure these concepts could be built. And even our friends actually at SNOMED, thank you so much, understanding how critical these concepts were to the success and coding requirements of the waiver. It was a very seamless relationship to get these into existence. And again, this is just a small example of the concepts that we built, and they all align again with the HRSN covered services table in the housing and home environment section. So rental assistance vouchers, 1 month's rent, real estate broker fees, repairing, medically necessary home modifications, mold remediation, utility arrears, utility activation fees. Again, all the provision concepts that we're able to support standards for CBO services that the social care entities are providing. Next slide. So that's the SNOMED concept. And again, the aim was within the recommendation, within the use case of Medicaid, armed with the covered services table, which is this national recommendation, to ensure there were SNOMED concepts that CBOs could use as standard testimony for what was offered to the person when they were communicating for payment from the payer. Of course, there's not sufficient HCPC concepts to map to all of those SNOMED concepts, but operationally what New York is doing and other entities are doing is creating basically guidelines to say SNOMED this plus HCPC this equals this, and more to come on that at some other day. We also just wanted to highlight that, of course, even if we use the SNOMED concepts in this kind of like roundabout way in New York, understanding that there are capacities for SNOMED concepts to represent reimbursement in future states, because it might be where we go. Right now, HCPCs are the lay of the land, and we again see them operationalized in waivers and in lieu of services arrangements across the ecosystem. So in addition to those SNOMED CT concepts, Gravity partnered with community-based organizations to represent critical concepts in healthcare common procedure coding system, or HCPCs, again, to support those CBO reimbursement waivers and in lieu of services. So our work this right now in fall 2024 and spring 2025 is food is medicine concepts with coding for food. We have our alternating calls on Thursdays with our normal new domain terminology development, including produce prescription, grocery provision, medically tailored meals, and then spring 2025, working on teaching kitchens and kitchenware. Again, all of these concepts, very clearly concepts that are represented and aligned with the covered services table and aligned with the Medicare and in lieu 1115 waiver and in lieu of services use case. And we already have a fair amount of interest in supporting housing entities with the same, again, state-based entities and community-based organizations, asking for the same degree of focus that we have in food is medicine, to focus on many of those core components that we saw in the SNOMED concepts, right? So SNOMED was the first push just to make sure there were standards available. And then we are we're working with our partners to see who's going to take lead on developing housing supports, just like we have been doing with food as medicine concepts. Next slide. And again, this is all trying to complete our requirement and for addressing recommendation number 1. And then lastly, as I mentioned, we have part of our work we're doing this summer and this fall again through this project is ensuring that all core social human services programs have a new part of our syntax. So right now enrolled in is not a common intervention syntax, but we, in order to meet the requirements and recommendations of this project and all of our CBO friends, again, social care voice co-design, we've heard very clearly from our social care friends, this is really critical. So we're going to be developing enrolled in blank program concepts to support documentation of enrollment in those core human services programs. And the important thing to note is we already built programs and definitions for all of these. We already have the representation of the concept in SNOMED CT because, as mentioned again in the chat, Gravity builds a definition for every single core federal program. So down to the Older Adults American Act Farmers Market Produce Program, right? So every single definable federal program to support social care and social needs, we go in and we develop in direct alignment with that federal definition. So now we're just going to be developing those enrolled in concepts around that existing program definition. It's following the precedent of what we built new when we were doing our health insurance coverage status domain. And so we built enrolled in blank insurance or healthcare coverage program. Again, referencing all those existing definitions, and examples would be enrolled in SNAP or enrolled in the HUD Housing Choice Voucher Program or enrolled in any core program. And again, this is important for two different things. Number one, it's an end outcome, like the goal. We're trying not to just represent the referral, but also what is the point, right? So enrollment is a critical outcome of most programs and care coordination and patient care and client care and person care. But also it's aligned with clarifying programs people are in currently, so you can build additional supports on top of them. And there are many of our 1115 waivers talk about needing to understand consistent enrollment in these programs for additional services. Whew. Okay, that was a lot of nerdy terminology talk. Next slide, I think that's it. So again, I just wanted to, my section of the presentation was really just demonstrating how terminology is focusing on addressing recommendation 1, granular SNOMED concepts to support all of the coverage for the covered services within the Medicaid and CHIPT covered services for health-related social needs, specific HCPCS concepts, and enrolled in concepts for core national programs that are critical for both reporting and outcomes and documenting to build additional services on top. Thank you so much, Emily and friends. And I think we're going to have some discussion, and thanks for your patience. Any questions? Or I think, but we're back to you, Corey, for the.
I have a question.
Okay. Hi, Matt. Yeah.
Hi, Sarah. Sorry to, dominate. Don't mean to be typical white male here. So my question is, where will the enrollment codes ultimately live? You mentioned it being in outcome, but I don't know, is that service request .outcome or task .outcome? And then if you imagine a use case where you might have a partnership with shared, let's say, SNAP enrollment with a Medicaid agency, so it's not like that SNAP enrollment is part of a referral per se, but you just want to record that, where would that enrollment data live?
We're working on that. I don't know if I don't think Monique is on the call. No, Corey Spear. Yep. It wouldn't. It's not going to be a procedure per se. It's going to be a finding more. Corey Spears. Which of the Corys?
Yeah, I would say in terms of the fire, where it's going to live in fire, I don't think we know yet. At least I don't know where that program but if you're asking sort of where it will live in the terminology, I defer to Sarah on that.
Yeah. So terminology is likely SNOMED based on the fact that they have built all the programs already. And we have it to be determined on where it goes. We had some meetings earlier last week on all the different options there. Yeah. Care plan was an option. There's all kinds of different options, but I think we'll actually, this is a where it lives in the spec is something that we'll definitely talk about over 2024 and 2025. The concepts haven't been, so that the concepts usually come first, right? So we'll build the language and then we'll work with you all collectively as a community to understand where best they can go in our ID.
I have another question, but if Kelly has got her hand up next, do you want to go next, Kelly?
Sure. I wanted to just expand on the enrollment questions. It's really exciting that work is progressing, and I'm curious, knowing that eligibility in some of those programs are month by month, if that is being taken into consideration in like how will true eligibility be considered, I guess.
Yeah, so we have thought about that. Varying eligibility month to month is not something that's new to clinical documentation, so just as we, one of the ways we imagine reconciling it is the same way we reconcile like medication lists, right? So it's like in some ways it's as protective as understanding, for a person to understand that they're enrolled in WIC as they are taking a certain medication. But again, it would have to have some kind of reconciliation process to be verified, I would imagine.
Okay, thanks for that.
You may not have a clear answer on my second question, because it was related to the first, was you talked about this conjoining of the HCPCS code, so you might have community health integration, this navigation service code alongside SNOMED codes, and would that live in the task resource or the service request resource when you're documenting those? Is there a way of documenting the relationship between those codes that, like, the SNOMED codes are kind of pointing at the HCPCS code or something like that? Does that make sense?
Sounds like a great thing to lean into in a future call, like right here. Matt, I love that idea. I don't know if we've decided that, but we are just leaning into crafting the concepts. And I'm sure we can come back along in a technical call shortly to lean into specifically. And that's exactly what we're thinking about, how to do this for 2025. So Corey Smith, is that okay to say that?
Yeah, that's fine. Matt, can I just ask you to just repeat the question? I agree with Sarah. We probably won't be able to answer it now, but I'd like to just make sure I understood the question so we can kind of think about it.
Yeah, so just to clarify, so you have a program like medically tailored meals, right? That you have the very clear authorization, yes or no.
Yep.
Is this person eligible, right? Then you have okay, that's clear, that's black and white. Then you have something like community health integration or some kind of generic service navigation or care management authorization code, right? That could be part of a waiver. But what actually happened? What was involved in that service navigation? What programs that are not directly covered by a waiver was the person enrolled in that is not directly covered, but SNAP was not covered by the waiver, but helping people enroll in SNAP might be part of care navigation or care management. Does that make sense? So
Yep.
you might want to point those SNOMED codes that are not, it's part of the documentation, but it's not like the official billing code per se.
Okay.
That is approved by the waiver. Does that make sense?
Yeah, thank you. Yeah, thank you. I understand the problem. Thank you. I don't have a solution right now, but I think I understand the problem.
Also was a little bit out of scope for this conversation, so I just want to be careful because hear you, Matt, always thinking about the intricacies of care planning, but just want to make sure, since we only have a few more minutes, that we give ourselves time, Corey Smith, to ensure that the actual the discovery standard elements were addressed before we close out. Sorry to take so much time. Do we want to have open discussion for this last?
Yes. I think this is I think people are asking. I'm assuming that people are asking questions here as we go along. But yeah, I think we're here to listen and want to understand, any reactions to this work that's just been presented to you. Do you have any areas that you think we should elevate, areas you think we shouldn't look at? We're here to listen and learn from you all. So please feel free to raise your hand or put something in the chat. Jonathan.
Hi, can you guys hear me okay?
Yes.
So I've been very vocal about this on some of the calls that I've been on. I believe that less is more at first, like when you try to boil the ocean, like you can always add more later. But I think to Lucy's question and point earlier, the ability to actually have a foundational base that you're going to utilize some of these concepts on based on commonalities that you can standardize across different systems to reduce portalitis is ultimately what's going to get you guys the momentum to make sure that you're headed in the right direction. And then once you do that, theoretically, it should make it easier for more stakeholders to come in and inform the process so that you're actually scaling what works instead of building in a bubble in a vacuum on what you think works. Does that make sense?
Yes, thank you.
Yeah, and to build on Jonathan's comment, sorry to dominate, it, the standards world will continuously be so far behind implementers world. You know, if we have to kind of play catch up each time by associating enrollment with the latest new program in the block, right? If there's any way that that can be done on a genericized level, or that there can be something in the standards to just find enrollment independent of what program you're talking about, would be ideal.
That's right. That's right. And so when they come to it, and I think, and I'm sorry, who had said it first, maybe it was Elena, who was talking about the funnel, right? And so when you think about everybody at the top of the funnel, and when they start to self-select, and when they find the path of least resistance, because there's commonalities and standards that have been put in place, it'll make it easier for them to identify that, which creates a feedback loop, and then they'll come back and tell you, hey, this doesn't make sense over here. What about over here? And then as you start to do that, you actually make the work for the implementers easier, but then it also allows them to inform you on the process. So then all of a sudden that gap shrinks a little bit. Does that make sense?
Yes, Lucy, I see Lucy has a hand. I'm just kind of going here quickly. Thank you, Jonathan. Go ahead, Lucy.
Yeah, I want to support what's just been said to the extent of suggesting that all future communication about this discovery and the work that follows should be framed as, this is a gigantic task. We have to prioritize. We have chosen this. We are not ignoring everything else. We are trying to build a foundation that everything else can be built on. It seems to me that is a basic message so that people don't think, looking in on this later, or even in the next hour thinking about it, that you think this is more important than anything else. It isn't. It's a place to start.
No, that's right. You have to start somewhere. And this is where we chose to start. And anybody else that wants to come in and expand on this foundational work needs to understand that. And then going forward, it's easier to then give feedback about what should be done. But I think that if you do too much up front, then Lucy, to your point, people are going to feel ostracized and left out of the process. And then it's going to be harder to get their buy-in in the future.
You just have to frame it that way. That's all I'm saying. Thanks.
Agreed.
All right, I think we're at the hour here. Yes, thank you all for your participation. This has been great. Emily, Corey, Sarah, everyone that's participated. We'll be taking our notes and we'll be reporting back here, you know, as to where we're come back to the terminology stream. As you see, Sarah already has work in progress, and on the technology stream, we will continue to meet here every 2 weeks and report back on what we're going to do next.
Thank you, Fran.
Thank you.
Thank you, everyone.